and thank you for joining this episode of Boston Children's Cardiac Conversations. Today, we'll be focusing on understanding a vascular ring operation. We'll start by introducing the panelists from the Vascular Ring and Airway team that are here today. My name is Linda, and I'm the cardiology nurse practitioner on the team.
Yeah, hi everyone. Thanks for joining us. I'm Dr. Sendejas. I'm one of the general thoracic surgeons of the team. Pleasure.
Hello, I'm Dr. Beard. I'm one of the heart surgeons on the team.
And I'm Leanne. I am one of the nurse practitioners under general surgery on the team.
Perfect. Our first topic of discussion today is about why some children need more than one vascular ring reoperation. Dr. Baird, how often do children have reoccurring symptoms after surgery, and what kind of symptoms are typically observed?
Yeah, so when patients have vascular ring surgery, they typically have it for either respiratory symptoms or feeding symptoms, so-called dysphagia, and sometimes both. And depending on the type of vascular ring and how long they've had those symptoms, sometimes will play into how long they have symptoms postoperatively. Frequently, what we'll see is that respiratory symptoms will often be resolved more or less right after the operation. And sometimes the feeding difficulties take a little bit more time to resolve, even if the obstruction has been relieved. So there's a good percentage of patients that early on may have some slight persistent symptoms, but those symptoms generally get better within the first weeks after the operation. In older patients that have really long-standing issues, and this is one of the reasons to not delay vascular ring surgery, it sometimes takes a fair bit longer for particularly the feeding issues to be resolved.
Dr. Zendejas, will you describe what generally causes recurrent symptoms in children after vascular ring surgery?
Yeah, so it's a variety of elements. And I think to go on a little bit to your previous question, the truth of the matter is we don't know what the proportion of kids that get a first operation require a second operation, mostly not necessarily because we see a lot of those kids, but the persistence of symptoms doesn't always prompt a referral or awareness of the possibility of the ring being incompletely addressed, or still there being incompletely addressed elements of the issue. What do I mean with that? It's not always just the ring, or meaning just dividing the ring is not only the element that needs to be addressed. Sometimes the airway compression or even malacia or weakness is present from the get-go, and if it wasn't addressed up front, that can be a cause of persistent symptoms. Similarly with the esophagus, sometimes the esophageal compression isn't fully resolved, or the ring components weren't adequately removed, or sometimes repeat scarring that can occur if particular elements are left too close to each other, can cause residual airway compression. So when we've studied this, we looked at a series of a lot of our patients that we reoperated on. We identified those elements as the main culprits as to why a child may have persistent or recurrent symptoms, which is unaddressed airway malacia, number one. Number two is residual compression of the esophagus, sometimes from vascular structures, and sometimes this mediastinal scarring, or just scarring in the area of the surgery, that led to some of these symptoms. So that's kind of like the general reason as to why it happens.
Okay, thank you. Our second topic focuses on a decision-making process for reoperation. Dr. Baird, why do some children need a second operation, and how common is this?
Yeah, so I think when we're trying to understand if a patient needs a second operation, frequently they're persistent symptoms or recurrent symptoms. In other words, there's worsening respiratory or eating difficulties. And so that brings it to our attention. So then it's really important to get a thorough workup. And we need the imaging studies, or the so-called diagnostic studies, that help define that. And sometimes that's with a camera looking down with a bronchoscopy, or sometimes with a scope down in the GI tract, or a barium type study to help really define if there are persistent so-called anatomic issues that surgery may help. So we first look for symptoms, then we try to get the imaging studies to define the problem, if it's an anatomic problem, that to determine if surgery could help. And then we try to look at those, combine them, and then have a discussion. Is the risk benefit ratio worth it? In other words, do we think we can get a good result anatomically to then allow the symptoms to be resolved? So I think there's probably, it really depends on frequently where you have your first vascular ring surgery and the type of surgery that's done to give a percentage of patients that require reoperation. But if you look at historical literature, there's a definitively a good portion of patients, maybe up to a third or even a half in some series, that have persistent symptoms. And then the question is, are those worth reoperating on? And we think it partly depends on if there's still anatomic disease that we think we can make better to help resolve those symptoms.
Okay. How often do you say, or would you think that a reoperation happens?
Well, it depends. If you took every vascular ring patient in the world that got an operation anywhere in the world, there's probably many, many patients that have persistent symptoms that should get a reoperation. The problem is that their providers are not confident that they can make things better. And so it's not really a fair question of how many patients get a vascular ring reoperation versus how many patients probably could benefit from one. But if you look at the patients out there now, there's probably on the order of 5 to 10% of patients that undergo a reoperation, or at least should be strongly considered for a reoperation after a straightforward vascular ring surgery.
Dr. Zendejas, do you have anything to add?
Yeah, I mean, I think the tricky part is the awareness of it being a possibility that there could still be unaddressed issues that will require an operation. Most of the time, unfortunately, kids have persistent symptoms. They go see their cardiologist, nothing against their local cardiologist, but sometimes they look at the scan or they look at the echo and they see, well, your vascular ring's been treated. Like, that, it is what it is. It must be something else. So let's go see the pulmonologist. Let's go see the gastroenterologist. And in isolation, each isolated specialty, if they're not talking to each other, they may see like, well, this isn't our expertise, or this isn't our part. It's that many kids unfortunately do bounce around for several months to years sometimes until they come to a team like ours that is sort of multidisciplinary, really understands the possibility of recurrent and persistent symptoms, and which are those cases that do require benefit from a workup, as Dr. Baird said, and potentially a reoperation. I think the awareness is something that we're working on. Yes, not every child with persistent symptoms or recurrent symptoms needs a reoperation, but I bet you there's a lot more out there that probably would, that just aren't being sort of aware of that as a possibility.
Thank you for that. Leanne, could you explain which records are reviewed with a child with a previous vascular ring operation who comes for a second opinion, and what further tests help to determine if the reoperation is needed?
Sure. So when we get a second opinion request for a child who has already had an operation for a vascular ring, what's really important is that we have the information about what evaluation has already been completed. So that includes what specialists have been seen for the recurrent symptoms. So for instance, have they seen a pulmonologist? Have they seen a gastroenterologist or a cardiologist? And what recommendations did those providers have, and then what specific workup or test have already been done. So if the child has already had a CT, it's very helpful for us to see the report, as more importantly the imaging for that, to kind of figure out what their internal anatomy looks like in relation to their airway and esophagus. If they've already had a bronchoscopy or an endoscopy, it's very helpful to look at that report, but also if there's any images or even better, video related to those tests, it's helpful for us to look at those to kind of assess what sort of external compression might still be present, or for the bronchoscopy specifically, is there any tracheomalacia that they noted on that exam? Are there any other anomalies present that could help explain the symptoms, like a laryngeal cleft is something that is sometimes looked for to explain recurrent respiratory symptoms. So the evaluation that's already been done is important for us to determine what's really needed going forward. And then, of course, as the practitioners, we talk to the family and we get a sense about what are the recurrent issues. So are they having swallowing symptoms? Are they having respiratory symptoms? What are the biggest concerns? And based on the symptoms and the workup that's already been done, we can determine what other tests are needed to kind of help us understand whether the child would benefit from a reoperation. We tend to err on the side of a little bit more information when it comes to reoperations, because we want to ensure that a second operation is done and it's the final one. So we might get a little bit, or might request a little bit more workup to be done to kind of figure out those pieces of information and determine how much vascular compression might be left, or if there's another issue like tracheomalacia.
Dr. Zendejas, why do some children need surgery again and others do not?
And it goes down to what can we see elements that we can improve on from an anatomical standpoint, particularly, and is the risk benefit ratio in favor of benefits? In general, it usually is. I think there's very rare situations where we say, oh geez, this is way too risky to try. I think that in general, most cases, the benefit, if there is obvious anatomical compression, obstruction of the airway or esophagus, it usually is something we can do safely and that get benefit from it. So I think it's that combination of elements.
Dr. Baird, do you have anything else to add to that question?
Yeah, no, I think that's right. I think in general, once we've proven an anatomic problem that correlates with the symptoms, frequently we can come up with a approach. And we have several. We could go through the front, or so-called sternotomy. We can go from the right side to the left side, and we tailored that approach to optimize, given that best outcome based on the workup.
Our last topic for today is how Boston Children's approaches a vascular ring reoperation. Dr. Baird or Dr. Zendejas, how does Boston Children's take a comprehensive approach to caring for children with vascular rings?
So, I mean, I'll just start by introduction, then I'm going to kick it over to you and Leanne, because that's really where it all starts. And I mean, the intake process is to me one of the greatest parts of the program, and then the follow-up process after the operation. Dr. Zendejas and I can talk about the operative parts like we've done, but Leanne or Linda, do you guys want to touch on that process, how it started through our coordinators, and exactly the intake? You touched on it a little bit already, Leanne, but maybe to expand on it just a little bit.
Yeah, so when we get any sort of second opinion request, we, after gathering all the records, we'll call the family and do a thorough intake, and that involves kind of assessing all the past medical history and figuring out what sort of symptoms are present. And from there, we can help discuss the case at conference and make recommendations. But if the recommendation is surgery, we follow the child throughout the process. So we would, of course, round inpatient, and then we would follow up outpatient at certain intervals post-operatively to make sure that things are going well and there's no concerns with recurrent symptoms or just concerns in general that we can kind of help troubleshoot. If it's not if we don't think surgery is recommended, we can also continue to follow the child and kind of assess whether the symptoms are are worsening at that point, and at what point like this needs to be a rediscussion with our team for surgery. But beyond that, I think in general, our team is multidisciplinary, which sets us apart from other institutions. We have a large group of specialists on our team that we all work together to kind of figure out the best approaches to these problems. And from that, we have specialists from GI that, are experts when it comes to vascular compression and how that affects the esophagus. We have experts in pulmonology who similarly are experts with tracheomalacia and vascular compression of the airway. We have cardiologists who specialize in this, and then we have ENT providers, speech therapists, nutritionists. So our team is very dynamic in terms of being able to come together as a group and have a discussion about what these symptoms are and trying to figure out the best solution to that. And that continues after surgery if surgery ends up, being recommended and happening. Linda, what do you have to add?
Yeah, so jumping off of Leanne, kind of, she more talked about the intake process and when the patients come for surgery, but kind of jumping off of after surgery, we do follow the patients for about a year out. So we see them at 1 week, 1 month, 6 months, and a year, and we're able to keep a close eye on their symptoms. And then we're also able to see kind of how their symptoms have improved, and if there's anything else that comes up, we're able to help address that as well. And then Dr. Zendejas, do you have anything else to add?
I think you hit on the elements, which is this sort of single intake situation where instead of going to all these different specialists and having multiple different intakes at each sort of specialty group, it's just one intake. You have sort of almost like a partner in Linda, Leanne, or any of our other team members that you'll get to meet, and they kind of walk you through the process. And that I think is very reassuring to families to know that you're going to get the input from all these different specialists and not have to sort of go through the whole process all over again at every single time point. I think it's a very unique setup. There isn't a single other program that exists that we are aware of that has been able to collaborate, coordinate with this degree of efficiency and seamlessly sort of just focusing on this entity. So I think it does offer that element, and then ultimately I think a lot of the elements of care that we're able to incorporate into treating these redo procedures or are very innovative in and of itself, and a lot of those innovations sort of started here, and so it gave us the advantage in order that we were already comfortable in our own sort of subspecialty groups using these innovations for other entities, that we were able to sort of bring them into this patient population to improve their respiratory symptoms, their esophageal symptoms, their cardiovascular health. And so I think that was sort of the magic that kind of came together.
Great. Do you think that there's, one type of surgical procedure or any key difference makers in treatment of vascular rings at Boston Children's?
I can briefly comment. I think if we had to say one, it's the dynamic assessment throughout the process, but really importantly in the operating room to fine tune that, based on, for example, the intraoperative bronchoscopy to make the assessment of how aggressive one needs to be. And I think that is really critical, because if you just go in to do an operation and don't assess it in any way, then you don't really know if you've accomplished what you set out to do. But I think from a surgical standpoint, that is critical. And I think the other aspect is from a management is a preoperative evaluation with you guys and a postoperative follow-up to help manage the expectations of improvement or failure of the operation.
As a follow-up, how and why is vascular ring reoperation at Boston Children's Hospital generally safe?
I can touch on a few points. In general, I think we address or try to tackle the elements that we consider at risk in a reoperation. Any surgery has sort of three big categories: bleeding, infection, and injury surrounding structures. And in general, those two first ones are usually not a concern to us, although working with blood vessels, it's usually in a very controlled environment, very safe. But the injury surrounding structure is one of the elements that is at risk in a reoperation, because sometimes scar tissue makes two structures that are not supposed to look the same. And this is where we've pioneered the use of what's called intraoperative nerve monitoring, which is a special technology or tool to help us protect the nerves that control the vocal cords in these kiddos. And that's unique because otherwise it's high risk for nerve injury. And so using this technology, we've been able to show substantial improvements in that regard, which affects their respiratory and swallowing outcomes. So it's directly relevant to what we're actually trying to treat. So that I think is a must, and sort of particularly in any reoperative setting, such now that we incorporate it even for all cases, even the first time operations, to not get into that problem. That and a series of other elements in terms of how we handle the esophagus, how we handle the airway, how we look at these things to do that. But I think also more importantly, doing a reoperative chest operation is something that you can't just do once a month or once a year. It comes with a lot of expertise of doing it all the time. And we're a team that, well, one thing or another, both Dr. Barrett and I, even in our own separate practices, we do a lot of reoperative surgery and then a lot of reoperative vascular surgery. So we're used to being in that environment. And so there's certain elements of care that we may take for granted because we do it all the time, but it may not be perceived as such for somebody who may do one or two a year or one or two a month kind of thing. So I think that's a big element of the expertise that comes with our team.
Great. And Leanne, can you provide an overview of the outcomes for children who have a vascular ring reoperation within the program?
Yeah, so we just recently published a study actually with 65 patients over 3 decades who had a reoperation at Boston Children's. And most presented with recurrent respiratory symptoms. About 2/3 had swallowing symptoms. But what we found was that it was, limited complications, and 75% achieved complete resolution of symptoms. So I'd say from that outcome standpoint, it is very effective. And then discussing the quality of life of the patient. We haven't done a study on this, but just in talking to families who their child has had a reoperation for us, a lot of them tell us this is really life-changing for them because, their child has recurrent symptoms and they've been told repeatedly that the vascular ring is fixed and they don't need a reoperation. And then they come to us and we do a more thorough evaluation and find out that they do have something, they do have residual vascular compression or tracheomalacia, after we perform the operation, their child is so much better. So I think quality of life is also significantly improved for these families. Yeah.
Great. Okay, so now we'll move on to answering some questions that were submitted from our parents, and I see 2 here. The question is, what is the minimum age when the vascular ring surgery can be done, or is there a minimum age?
Yeah, I think the answer is there's no minimum age. We've done it in newborns as few as as early as a week old or so, but it's pretty rare you have to do that. And again, it's based on, I think, symptomatology and the etiology of the disease. But so to answer the question, there's no minimum age. And then to pick out more common ages and more routine ages, it depends on the type of vascular ring or the type of absolute diagnosis.
Okay. And then kind of jumping off of that, it's a little similar, but does age affect needing a second surgery, such as if the patient had their first VR surgery at 1 month old? So kind of given that age, does there need to be another operation at a later time?
Yeah, no, I think that the age at first repair doesn't necessarily give you a greater risk of a reoperation if it was done properly. I think that it can be done improperly, I guess is a way, or incomplete at any age. And so I think it's just like where all the elements of the condition addressed or evaluated and treated. And I think that's what dictates more the likelihood of having another operation.
And then the next one, how do we as parents and advocates approach this with medical professionals who are unfamiliar or underestimate the severity of vascular rings? This parent rates that many of us have been brushed off by other medical doctors when we voice our concerns.
I think, one simple way to do it is actually how a lot of families get to us. The parents just ask for another opinion. And then they can go through the process that we've just described, and we're happy to give that evaluation back. We typically give a formal written evaluation summarizing our thoughts. And that way it kind of takes the burden, off the families outside of asking for that opinion.
Anyone else have anything to add?
I think it's the awareness of bringing the possibility of like, hey, could this be that? Can we get a second opinion? I've heard from so-and-so. There's a lot of social media groups that parents get connected and talk amongst each other, and there's a lot of sort of valuable information there, and reach out to us. And I think it's a good idea to sometimes we look at things and say, hey, there's nothing really here to do differently. Things look really good from an anatomical standpoint. It may just be time. Or actually, maybe we need to look into these other reasons for persistent symptoms that may not necessarily need our reoperation. So I think it's important the bottom line is there shouldn't be persistent or recurrent symptoms. If they are, and they persist more than a few weeks, I think reach out, obviously to your local team first, but if you're not getting anywhere, definitely reach out to us.
Great. And then the last question here, this person or this parent writes, when should the esophagus not be compressed after a vascular ring surgery?
It should never really be compressed after vascular. I mean, I think you should finish the operation with that esophagus without any compression. I think the vast majority of the time it's not even touched or moved by most surgeons, particularly if it's approached from a just dividing the ring standpoint. But and that may be okay in some cases, but more often than not, particularly if the compression has been there for a long period of time, there is a lot of scar tissue around the esophagus that often traps it or keeps it in a fixed position, sometimes even behind the airway. And that's what contributes to some of the persistent recurrent symptoms. And so you sort of do have to get rid of some of that scar tissue to allow the esophagus to move a little bit and shift. Now, we occasionally have to move it even more when we have to do additional procedures like tracheopexy or aortopexy to get room to improve the airway in the esophagus. So that there are different degrees of how much we move the esophagus, and not everybody needs it to be moved substantially. So in general, we try to be gentle with that because we do know that if we move it too much, it can sometimes be noticed by the patients and make some symptoms different that we can still address, but it is something that we take into account.
I agree. We talk a lot about, symptoms and indication for surgery. One question that a parent had is, do you recommend repair for patients who are asymptomatic versus waiting and watching?
Yeah, so I think there's two ways to look at that. As I often will say, and when we're reviewing patients, if you're truly asymptomatic, for most situations, it's probably okay to wait. But on the flip side, if there's a diagnosis and the parents are asking frequently their symptoms, if you ask the right questions, and then you guys are kind of the expert in asking those questions. And I mean, you may want to comment, you or Leanne, about that, because you guys know the right questions to ask to elicit the responses. And frequently what happens is when a parent thinks they're not symptomatic and you ask a question like, oh, actually that does happen.
Yeah, I can kind of jump off that a little bit. So typically, I think if you were to ask, for example, maybe an older kid or a teenager, if you were to ask, do you have any swallowing symptoms? They may say, no, I swallow fine, I'm okay. But if you dig a little bit deeper and ask, well, do you have to cut your food really small? Do you feel like you're drinking a lot with bites? they may say, actually, yes, I do have to do that, but in their mind, it's something they've done their whole lives and they think that's normal, when it may be a symptom, but sometimes you wouldn't always know that unless you ask them those correct questions. And do you have anything else to jump on for that?
Yeah, I mean, I think that, we get a handful or more second opinion requests every year that of parents who have learned about this diagnosis prenatally, because it's becoming more and more common to learn about it on the prenatal ultrasound. And they want a second opinion about whether their child is going to need surgery. And often, it's during infancy when there are no symptoms. And there are specific type of vascular rings that are more inclined that you will have symptoms just because they're known to be tighter, like a double aortic arch. But there are some, like a right aortic arch with aberrant left subclavian artery. If it's looser, they may not develop symptoms in infancy or ever. We do want to follow those patients still. So although, we get a second opinion request that the child doesn't have any symptoms, even when we do ask the right questions, and our recommendation is to watch and wait, we're not just going to leave it at that. We will continue to follow up periodically to determine if symptoms develop, because often they will. But, there is a period of monitoring when there's not symptoms, and typically we won't recommend surgery unless there are symptoms or symptoms developing.
Thank you. Two more questions we have submitted by the parents. How often do you see the diverticulum of Commerell that has become formed into an aneurysm over time?
Yeah, I think that this is a little bit semantic in the terminology. In other words, some people see these diverticulum of Commerell as aneurysmal. And if you to really be defined as aneurysmal, you have to look at the pathology and define what the actual intimal wall is. It turns out, I think these diverticulum of Commerell are typically larger than the subclavian artery and frequently larger than the aorta in some situations. It doesn't necessarily mean they're aneurysmal. It's very infrequent that they actually almost never rupture. So when we have an aneurysm, we worry about it getting larger to the point of rupture. The diverticulum of Commerell rarely ruptures. There's very few reports of that. However, as they get bigger, they can cause more compressive symptoms. So I think that, the terminology aneurysm may be less important, but the size of the diverticulum and its compressive effects or the external compression is the real factor.
For patients that have a diverticulum, do you recommend monitoring or follow-up imaging at any particular period of time?
So for all patients with vascular rings, as you guys pointed out, and I think Leanne just commented on it, even if these folks are asymptomatic, we like to follow the patients. So we'll continue to follow those patients, and over time, they'll get repeat imaging studies if the decision was to wait. And the fact is if it continues to grow, the patients generally become symptomatic. So in that sense, we recommend continuing to follow patients with vascular rings for symptoms and for change in the anatomy or growth of the diverticulum.
Our last question is for those who had esophageal mobilization and esophageal dysmotility, for those who had esophageal mobilization and esophageal dysmotility occurs, what can be done?
Yeah, that's a pretty good question. We're trying to understand it a little bit better. It doesn't happen to everybody, and it's also based on the degree of esophageal mobilization. We talked a little bit about it earlier. Kids get different degrees of mobilization due to the need to do additional procedures to improve the airway or esophagus sometimes. Now, we are doing more and more studies to look at the motility potential effects even before surgery. Our GA team's doing some procedures called endoflip or measuring contractibility of the esophagus before we divide it and after we divide it, try to understand is that dysmotility, was that dysmotility present beforehand? Or is it truly new after the fact? I think in general, we first have to make sure that there's no residual anatomical obstruction, right? So there has been sometimes that even after we've operated, there is some residual anatomical issue that often is more likely related to angulation of the esophagus and some scarring as to how the esophagus is a mobile structure. So although we leave it as straight as we think is possible, sometimes it moves in a position that kind of scars in a funny way, and that scar tissue can be broken up with endoscopic dilation. So some of those kids have responded to postoperative endoscopic dilations. Fortunately, one or two usually does the trick if that's really what it is. So here it's understanding that there's no anatomical issue. We may get an esophagram, we may do an endoscopy, we may do a dilation to kind of try to break up some of that scar tissue. That often resolves it. If not, then we have to look at, is it some issue with the stomach emptying? Do you need to inject a little Botox to the pylorus? Do you need to hit on some promotility medication? Is it a component of reflux? So there unfortunately isn't a great pill or medication that directly affects the motility of the esophagus. It's also trying to affect the downstream effects of the stomach emptying a little quicker, so the esophagus empties quicker. And so I think the bottom line is trying to understand what the reason for the dysmotility is. There are some rare cases where you're right, it just seems like the esophagus doesn't move as great. And we have to be careful with all of that. So short story is, we don't know the reason for every single case. We are trying to get to the bottom of it. Most of the time we can figure it out, and there's usually something that can be done to address that. So in your particular question, we'd have to look at the details of that scenario to kind of answer it completely.
I will say, just to add on to that we've had cases where there has been like documented esophageal motility issues or esophageal dysmotility. And we have our GI providers are experts in this. And one thing that they have recently, well, over the past couple of years been doing is there is a medication called Motegrity that is off-label use for this, but it can be life-changing for a lot of patients with esophageal dysmotility and help with dysphagia if that's what's going on. It doesn't work on every patient, but it can be very effective. And so, if we had a patient where we've done all the tests and really this comes down to the child still choking and it really is esophageal dysmotility related, our GI providers could weigh into that and see if something like Motegrity could be started that could help improve symptoms.
Great. Thank you, Leanne. And then we have another question from a parent. If the arteries on the heart are backwards, heart is in the normal way, this parent writes, does that make the vascular ring surgery harder? So I guess maybe what elements during the surgery make it harder?
Yeah, so I think there's a number of factors there that we would have to understand to really answer that question. I mean, would it be talking about the original surgery or would it be talking about the reoperative surgery? And when one says the arteries are backwards, from the heart, different people think of different things that way. But I think in general, reoperative surgery is typically a little bit more challenging because there's more scar tissue and more potential damage one could do. The nerve is often scarred in. There's often more difficult planes to dissect through, regardless of which side of the heart it comes off of. So we're, as Dr. Zendejas alluded to earlier, we're fairly confident and comfortable in dealing with the redo dissections and the unique anatomy. So it's not that part that's so much of a challenge for us. I think really the most important thing for us and the challenge is really trying to understand if there's symptoms that we can affect by improving the anatomy.
Great. Are there any more questions in the chat? So that's all the time we have today. Thank you to Dr. Baer, Dr. Zendejas, and Leanne for this discussion. Parents, you can check out the Boston Children's Vascular Ring and Airway program page for additional information on our program and our approach to reoperations. And this recording will also be added to the BCH YouTube page and to the website as well. Thank you everyone for joining.